Thank you very much, Rory. Yes, I found it quite hard to work out what I was going to talk about today, particularly because it feels a bit uncomfortable to be stood here taking credit for work that actually the majority of you have all done. But I think the format is I'm supposed to talk a bit about me and then talk about what I, or rather you, do in our trials world here at CTSU. So I'm going to start by going back to secondary school, where I was one of those children that was annoyingly good at maths, much to the frustration of my older brother Matthew. I think my parents possibly worried that I might have peaked a little bit early after my first year maths exam. But I managed to keep up the decent scores. Oh, this is forwarding very fast, sorry. I kept up the decent scores, and by the time I was finishing my A-levels, my teachers had pretty much run out of stuff to say. But why am I telling you that? Well, in my mind, the way that we approach clinical trials is really very, very similar to maths, and I think that's possibly why I love it so much. Perhaps the hardest bit about maths, for those that don't get on with it quite so well, is working out what the question is. And here's a really prime example. Lengthy descriptions of table sizes and fabric, but really, so long as you know how many inches there are on a foot, for which you need to be old enough, and what the word diameter means, then it all turns out to be really extremely straightforward and very easy to get the right answer. Sorry, I'm clicking too fast. Which brings me to the next great thing about maths, which is simplifying stuff. And this would be an absolute dream GCSE question to me if I'd been young enough to take GCSEs. Take an equation that looks incredibly complicated, clear out all the bits that you don't need, and find that the whole thing really was extremely simple, after all. And then there's rules. So there's a few basic principles in maths that you need to know about, but once you do know them, you find that they help you to sort out pretty much everything. And you don't need to rote learn pages and pages of formulae. You just use your basic rules and you apply them, and it all works. And then finally, even in maths, there's a time and a place for accuracy, and actually being able to make sensible estimates. Checking if your answer is roughly the right order of magnitude often gets you the majority of the marks, so you don't always need to drill down into the fine detail all of the time. So I'd like you to remember these ideas as we move on into clinical trials, because I know they're very familiar concepts to many of you. But first of all, back to my story. Time for me to decide what was I going to do after school. Well, even in the pre-Athena Swan era, my school was very keen to encourage girls into maths and science, and there was a lot of enthusiasm for me to do engineering. It all seemed a bit much like physics, which I was quite good at, but I didn't really enjoy it very much. Maths was obviously an option, but I wasn't quite sure where that was going to lead me, and I was really keen to pursue something quite practical. Both my parents were dentists. Mum was a general practitioner with her surgery in the basement of our house. Dad was an academic with a specialist interest in restorative dentistry. But their practical skills extended well beyond just teeth. My mum is remarkably green-fingered. I was brought up sharing her love of all things horticultural. Here she is, being dwarfed both by her granddaughters, but also by this year's really impressive amaryllis plants. And from a young age, both my brother and I helped out in the garden. Here I am doing a fine job of hurling soil into the air, while Matthew actually put his back into the job and did the work. My dad, on the other hand, took his DIY hobbies really to extremes, with the love of restoring old houses. Here's the cottage in Wales that I think some of you have heard me talk about. And it was a major part of our childhood and a place to really put practical skills to the test, lovingly restored over several decades. And by the age of 13, I was pretty proficient actually at plastering, brickwork, tiling, and even dressing and laying Welsh slate. And here's me and Dad finishing off a section of the roof. You can see 1980s health and safety really at play here. So at some point I decided that probably medicine could be a good compromise. I had plenty of science, but lots of practical skills. So I got a place at St Catherine's, at the other place, to study medicine. And I have to admit, I really had a great time in Cambridge. I worked just about hard enough, had to resit a few exams. I did a very good job of bringing my exam marks down to something a lot more reasonable. And I played pretty hard too. And 28 years ago, nearly to the day, I had my first encounter with the darker blue world in the women's rugby varsity match. I don't really consider myself anything of an athlete at all, but if you're 6 foot tall, then you typically can get yourself a place in the line-out, even if I rarely touch the ball at any other time in the match. I think that's probably my distinctively bony hand just over the side of the picture there. And I do seem to be on the wrong side of play. I think I haven't quite made it back to the right side, but there we go, you get the idea. And I have to admit that Oxford completely slaughtered us on the pitch at the time. I'm not even going to tell you what the score was. Although I do think we did a better job of seeing them off the tables in the pub at the end. And I might also just note that the women's team at the time didn't even get a blue for their efforts. In fact, we didn't even get a half blue. I'm not bitter, of course. And actually, we weren't even allowed to play on the university pitch. The one game in 2 years that we wanted to play on the Cambridge University rugby pitch, and we weren't allowed to because there was some inter-college men's football match going to be happening later in the week, and they didn't want us to mess up the pitch. I'm glad to say that the women now get to play at Twickenham, just like the men. Sorry, I'm having mouse difficulties. Let's carry on. Okay. So, I qualified from Cambridge in 1991, and then I came back to London, my hometown, to do my clinical training, and went to St Bartholomew's Hospital Medical School. Finished there in 1994, and then proceeded with a pretty standard general medical training for the next few years. I did my first house job at Whipps Cross Hospital in Leytonstone, the East End of London. Had the highest rate of admissions in the UK with gunshot injuries at the time. And then I did my house surgical job at the Homerton Hospital in Hackney. That had the highest rate of admissions with stab wounds at the time. And then I did an A&E job at Old Church Hospital in Romford in Essex. That was just around the corner from the largest nightclub in Essex. So you can imagine Friday nights in A&E were always quite eye-opening. So I decided I'd had my fill of inner city medicine. I'd learnt an awful lot, but it was time to move to the leafy suburbs, and got a medical SHO rotation in Guildford. And by then I was starting to develop an interest in diabetes. It was quite mathematical. You had lots of clever adjustments to insulin that those diabetologists do that all seem like they know what they're doing, but actually I think it's mostly guesswork. And it was, though, a speciality that was really very general. You had to remember to look at the big picture in diabetes, because patients with diabetes have so many things wrong with them. So it really did appeal to me from that point of view. So I got a 2-year post as a registrar in diabetes, first year in Reading, and the second year in Oxford. And that was what brought me here in the first place. That was all very well, but in order to progress up the ladder then, I needed to get a training number. I didn't have one for those 2 years as a registrar, and in order to do that, I needed to do some research, which quite frankly I really didn't want to do. Diabetes research at the time was mostly involving taking willing volunteers and putting them in a clinic room and hooking them up to insulin on one side and glucose on the other side, and sort of adjusting the infusions, carefully titrating things. All sounds really mathematical. Taught you something about insulin resistance, but I wasn't entirely convinced it was going to make a huge difference to population health, and it really didn't kind of tick my boxes. But then a post came up at CTSU working with Jane, and it was for the closing stages of the original heart protection study. I was lucky enough to get the job, although it wasn't for some time afterwards that I realised the post had actually been created for Martin Landray. Martin was in Birmingham at the time, and he'd been working with Colin on some renal stuff, and the plan had been to enable him to move to Oxford. You know how posts are created to enable things to happen. But fortunately, Rory and Jane and Colin all decided there was more than enough work for both of us, which there definitely was, and created 2 posts. And Martin's always joked that I got his job. So September 2000 brought me to CTSU as a junior research fellow, and the closing stages of the heart protection study, which really was a most remarkable trial. It was looking at 2 different comparisons. On the one hand, simvastatin at a standard 40 milligram dose compared with placebo. And then totally separately, it was looking at an antioxidant vitamin cocktail, again compared with placebo, and treating people for an average of 5 years. The trial was truly elegant in its design. 20,536 participants, all in the UK, randomised at a very small number of sites. Really simple eligibility criteria based on previous disease, and a very broad age range, which meant it included a really general population. My job was mostly the adjudication of events, lots of them. And over the course of a year, that's pretty much what I did, I have to say, day in, day out. But when the results were finally announced, I sort of felt that I personally knew every single heart attack and stroke that had contributed to them. And the results of HBS were absolutely unrefutable. Very, very clear and definite benefit in the group who received simvastatin compared to those who were only taking the placebo. And it was across the board in everybody. So it didn't matter what your background disease was, it didn't matter how old you were, if you were male or female, whichever way you cut it, it worked. There was no denying it. Very clear results. And it really was a landmark study that changed clinical practice. And for me, a really remarkable introduction to clinical trials, with headlines like these coming out the day after the results were announced. So a year before, I was a junior diabetes register, and then I had the opportunity to present these major results to audiences of professors of cardiology around the world. You can imagine I was quite enamoured with the idea of trials by this stage, and perhaps research wasn't so bad after all. But at the same time as all of that was happening, the SEARCH trial was taking shape. I hadn't been involved in the design of SEARCH or the early stages, but I very soon took responsibility for much of the day-to-day clinical oversight. SEARCH was also a factorial design, so looking at two separate questions, comparing the effects of an intensive statin regimen of simvastatin 80 milligrams daily with a standard dose of 20. And then separately looking at the effects of homocysteine lowering with folic acid compared with placebo. And to cut to the chase, the folate didn't work, and the higher dose statin was more effective than the lower dose statin. And that was totally consistent with other trials at the time. But perhaps the key findings of SEARCH actually related to the effects of high dose statins on muscle. Very early on in the trial, it became clear that the rate of clinical myopathy, in other words, a significant rise in the muscle enzyme creatine kinase, which was accompanied often by very dramatic muscle symptoms, was higher than previously expected. And it seemed to be very clearly associated with the higher dose statin. And furthermore, we also noticed an association with the use of the antiarrhythmic amiodarone. And so during the course of SEARCH, the label of simvastatin was actually changed to reflect that, which was quite exciting to contribute to that. And indeed, by September 2006, we'd accumulated probably the world's largest case series of myopathy. And I'd had the opportunity to speak to the majority of those patients during the course of their investigations. As part of my job, I reviewed all the blood results that came in from the patients, from the clinics every day. And along with cases of definite myopathy, Jane and I started to get a sense that there were some near misses happening out there. Here's an example. So this patient was entered into the trial before I joined CTSU, screened in November 99, randomised in January 2000, and you can see their CK and ALT levels very consistent across those two visits. And we know that individuals typically have a sort of level that is normal for them. It might be at the top end of the range or the bottom end of the range, but it usually stays pretty consistent over time. This patient came back for their first visit a couple of months later, and both the CK and the ALT had jumped up quite considerably. No muscle symptoms, they felt absolutely fine. So Jane had the courage of her convictions at the time, before I came, and carried them on treatment, and sure enough, those blood results started to settle. This was just a week later, and onwards, everything was looking fine. And so they went, another couple of years, a whole bunch of results looking pretty much the same, and then another blip up with a slightly higher CK, not to the levels that it was at the beginning, but still going up, and with the ALT going up as well. And onwards we go. They come back down, they stay the same for another couple of years, maybe a little bit higher towards the end there, and then a few more blips up and down towards the end of the trial. This patient carried on treatment all the way through, didn't have any muscle symptoms at all. But they just looked a bit worrying somehow. And I started to gather a file of these cases, and over time Jane and I thought there probably is going to be something in this. We need to look at it a lot closer. So I worked with Sarah Parish to see if we could find a pattern. It was all getting quite mathematical now, so I liked it. And I had my pieces of paper with the results on, and Sarah had the trial database. And we went back and forward with various algorithms to see what worked, wanting to get all of my cases into the group that were identified, but not get extra cases that I wasn't so clinically worried about. Eventually, we settled on what looks like a rather convoluted solution, but it managed to capture the majority of the ones that I wanted into the group without including others that I didn't want. And there was some reasoning behind this slightly peculiar looking algorithm. We wanted the muscle enzyme level, the CK, to be high enough at absolute terms, that it was something that we were going to worry about. But it also had to be high compared with the patient's normal level. So somebody that was always at the high end of normal, their level really needed to go significantly higher for us to be worried about. So it had to be a multiple of their baseline level. And we also had to have a rise of the ALT level equally in relation to their baseline level, compared with what was normal for that individual. It didn't seem to work if you just used upper limits of normal from population figures. And we also didn't want to include people who had other instances of abnormal liver blood tests, because there was probably something else going on in those patients. And we found 55 cases identified by that algorithm. And the first bit of excitement was when Sarah looked at those. We did all of this blinded to their treatment allocation. And then Sarah unblinded them. And 49 of those 55 were indeed on simvastatin 80, identified by the mathematical algorithm, which had sort of given us a hint as to what dose of drug they were taking. The geneticists then got involved because we thought, really, there's a key question here. Are there specific genetic variants that are associated with the development of myopathy in people on high-dose statin? So they set up an experiment, a genome-wide association study, using the cases of definite myopathy, the people with really, really high levels of CK and muscle symptoms, but also our incipient cases, these algorithm-derived cases, and compared them with 90 controls, the people who weren't experiencing these either definite or incipient myopathies, but who were all also taking simvastatin 80 milligrams. And when the genome-wide association study was done, it came up with some really very interesting results. Now, these are the sort of plots that geneticists produce, and I'm not the best at describing them, I have to say, but in simple terms, each of the coloured bars along the bottom there is a different chromosome, and each of the dots in the bars is a different gene. And there's a red line across the middle there, above which statisticians start to get excited. Because what that tells us is that anything that appears above the line is quite possibly suggesting a genetic variant that could be linked with the disease that you're interested in. And sure enough, one particular variant stood out as being highly likely to be linked to these cases. Even more excitingly, it seemed to be linked to the cases both of definite myopathy, but also those ones that we picked up with our mathematical algorithm. That was very exciting for me. And this was really a very, very important finding, because it's helped us to better understand the basis of this rare but potentially very serious effect of high-dose simvastatin. And with that dose is no longer recommended and is largely withdrawn from use as a result of our work in the SEARCH study. Particularly importantly, the maths worked. So let's move on to the next study, Ascend, which was the first one that I was around for at the beginning. Jane and I designed Ascend way back, 2002 or so. I think we started thinking about it, and I know many of you have been hearing about it ever since then, quite frankly. But for those who haven't, Ascend stands for a study of cardiovascular events in diabetes, and it's really trying to address the very, very simple question. For people with diabetes who haven't yet had a heart attack or a stroke, is low-dose aspirin beneficial? And are omega-3 fish oils beneficial? And are these treatments safe? You'd like to think in the 21st century that we might know the answer to those questions. I mean, aspirin has been around for over a century. It sort of laid the foundation stone of the modern pharmaceutical industry. And fish oils are taken by millions of people around the world for no clear reason. And on top of that, 425 million people in the world have diabetes, with all of the extra risks that brings with it. You'd think that we knew by now whether we should be using these two simple treatments in this particular group. But we didn't. And why didn't we? Well, money. Those two drugs, aspirin and fish oils, are very cheap. You're not going to get good amounts of funding, certainly not from the pharmaceutical industry, to run the sort of size trial that you need to answer the question reliably as to whether those two agents should be used in this population. But it's a really important question. It needs answering. There's 425 million people with diabetes. We need to know what to do. So we had to think a little bit outside the box and think of a way of running a trial that was very streamlined, highly cost effective, really simple. We kept things absolutely to a minimum and did just the bare minimum of what we needed to do to answer the question. And one of the key things was that we adopted a male-based trial design. So we got rid of study clinics, they're very expensive, and used the post. Made the most of those quaint English post boxes that are on every street corner that people in the UK can access, and if you've got diabetes it means you have to walk to it, so that's good as well. And we designed questionnaires that could be sent to patients, asking them to fill in some very, very simple bits of medical information, and then return them to us free post. And we designed study treatment that could be sent out in the post as well. Worked with a company in Wales to design boxes that were going to fit through letterboxes in the UK, so people didn't have to go to the sorting office, because that wasn't going to happen either. So a lot of planning went on in terms of the design of this, because it really was necessary to know that it was going to work if it was going to be a success. And with those mail-based methods, we were able to really reach places that other trials couldn't reach. Up and down the country, all you needed was a postman and a postbox, and you could be part of this study. So the trial overall was a great success. We recruited 15,500 patients just in the UK. They were all aged over 50, they had diabetes, and they didn't have cardiovascular disease at baseline. That was part of the criteria. They were randomised to receive fish oil capsules or placebo, and then separately to receive aspirin or placebo. And we followed them for a remarkably long time, certainly felt it, nearly 7.5 years. And it's an absolute testament to the small but really dedicated Ascend team, and you know who you are, who worked tirelessly to manage to pull this off. It was a huge amount of work to manage to get patients to return their questionnaires, to follow up people when they hadn't done that, using these remote systems over such a long period of time. And it really was an incredible success. And I think to some of us, it feels a bit like a lifetime. Indeed, I've always had a rather personal barometer of just how long Ascend had gone on. I was on maternity leave for the first time when Jane came to see me to get me to sign the application for funding from the British Heart Foundation, which I signed just 3 days after Zoe was born. That was only the start. It took us a bit longer to get the funding that we needed and to go through all of the necessary approvals and jump through the hoops. We didn't start recruitment for another couple of years. And indeed, I missed the first randomisations because I was on maternity leave again, having just had Ruby 3 weeks previously. But I think I can safely say that both Ascend and my daughters matured pretty well over the next decade. And the study also provided me with an MD thesis, which I have to thank the Ascend team for. I feel really guilty that I got a degree on the basis of your work, but thank you. And by 2018, we were ready to announce the results of the trial. So to summarise it, the fish oils didn't seem to do anything. They didn't reduce serious vascular events, and this is low-dose fish oils, worth remembering. But across that whole 7.5-year follow-up, one of the longest ever follow-ups in a study of omega-3 fatty acids, there was no evidence of any benefit. The aspirin didn't have any benefit on cancer. That was a hypothesis that had emerged really during the course of the trial, and something that we were in a very strong position to address. This is just looking at the effects on gastrointestinal cancer, but it didn't affect other cancers either. The aspirin did, however, reduce the risk of serious vascular events. About a 12% proportional reduction in those major events in the people who were taking aspirin or allocated to aspirin rather than those who were allocated to placebo. But overall, that was largely counterbalanced by a hazard from the aspirin in terms of it causing major bleeding. Jane and I presented those results at the European Society of Cardiology last summer. We had 2 major hotline sessions in front of an audience of about 2,000 people, which was a bit less daunting than this. We managed to have simultaneous publications in the New England Journal, 2 publications side by side, and they even did this rather nice little video as well. If anyone wants to have a look at that, it's a lot quicker than reading the paper. And there was a lot of interest in the trial, a lot of press coverage, and in fact we still get a lot of queries about it, both the aspirin and the fish oil components still going strong. So Ascend was really my training ground, and beyond the science of it, which is very important, it really taught me a lot about clinical trials. And if we go back to that theory of just having a handful of simple principles, I'd say these are what the principles are for a good trial. You need your important question, first of all. It needs to be something that really matters to patients, matters to doctors. And then you need to answer it reliably. And it goes without saying that you need to keep your participants safe. But the reliably bit is certainly the place where an awful lot of people fall down. And if you're going to do that, you need to have a clear plan. You need to think it through before you start. You need to think about the protocol. You need to think about the practicalities, every bit of it, what size the cardboard boxes are. Are they going to fit through letterboxes? And you need to make sure that you've got funding and a suitable way of organising your trial. And then eventually you need to think about the rules. A lot of people doing trials get very worried about the rules surrounding trials. And I would argue that as long as you've got the principles right, as long as you're going to keep your patients safe, and as long as you're going to answer the question reliably, then you're probably following the rules anyway. The rules are often very over-interpreted, so you shouldn't let them lead you. And there's always a place to simplify. You should simplify absolutely everything within reason, I would say, in a trial. Simple protocols, simple eligibility criteria, simple documents, simple ways of collecting data. Don't collect things that you don't need to collect because they just get in the way. It's a little bit like medicine. We have a horrible habit in clinical medicine now of measuring things just because we can. And I think it's made clinicians slightly forget to think about their diagnostic skills. And again, simple procedures. Don't do things that you don't need to do. Only do the things that you absolutely need to do to answer your question. And yes, there is a time and a place for detail. I would say mostly that's if it's something that's going to affect your statistical power. Be very, very careful about anything that's going to affect statistical power. Check it, recheck it, and look back at it when things have changed. And sometimes you do need to change your plan. So, for example, in Ascend, we originally set out to recruit 10,000 patients and follow them for 5 years. But after the first couple of years, we noticed that actually the event rate, so the number of people having heart attacks and strokes, was quite a lot lower than we'd expected. It's great for the patients, but it's really bad if you're a trialist, because you're not going to get a reliable answer. So all we could do was make the trial bigger and go on for longer, because otherwise all our work would have been in vain. So that's what we did. We found another 5,000 participants and we persuaded them all to carry on taking the tablets for that bit longer. So the detail where it's needed, but not necessarily in all places. So let's move on to the last couple of studies. Again, things that are familiar to many of you, I'm sure. The REVEAL trial. REVEAL was looking at a drug called anacetrapib, which is an inhibitor of cholesterol ester transfer protein, CETP, which is a protein that does very effective things to lipids in the blood. It doubles, or in this case, it doubled the good cholesterol, the HDL cholesterol, and also lowers the bad cholesterol. And so in REVEAL, what we set out to do was to assess the efficacy and safety of this new agent, an unlicensed drug, by comparing it to placebo in people who are already being treated with a good dose of statin. And we did that in 30,000 people, all of whom already had established vascular disease. This class of drug had a bit of a checkered history before REVEAL. It started with the drug torcetrapib, the earliest member of the class, and that was studied in a trial called Illuminate, the results of which were published in 2007, before we were even thinking about REVEAL. They had 15,000 patients in their trial, and the drug certainly seemed to do the right things in terms of lipids. It increased HDL cholesterol, it lowered LDL cholesterol, but they had to stop that trial early after just only a year and a half. The reason? Actually, it was doing the wrong things. It seemed to be causing cardiovascular disease rather than preventing it. And it's probably due to effects on blood pressure, but clearly not a good start to this class of drug. So that was quite rapidly withdrawn. The next one up was dalcetrapib. That was studied in the DAL outcomes trial, which was reported just while we were still recruiting into REVEAL. They had 16,000 participants. That drug was a little less potent. It only had a rather modest effect on HDL cholesterol and did pretty much nothing to LDL cholesterol. And that trial was stopped after just 2.5 years, again, sooner than expected. But in this instance, because it really wasn't doing anything, there was no hazard, but there didn't seem to be any benefit emerging, and the decision was taken to just stop at that point. Next up, evacetrapib, which was studied in the Accelerate trial. And that trial announced its results just as we were in the closing stages of REVEAL. That drug's quite similar to the anacetrapib that we studied in REVEAL. Their trial had 12,000 people. Similar effects on lipids, so more than doubled the HDL good cholesterol, reduced the LDL bad cholesterol. But again, that trial was stopped prematurely after just over 2 years of follow-up. Again, because they didn't seem to be seeing any benefit. This is the graph from their publication. I've always thought it looks like they've drawn it with a Sharpie pen. But there's no doubt that those two lines don't seem to be separating at any point. So in terms of the primary endpoint in that trial, after 2 years of follow-up, there wasn't a suggestion of benefit from this drug. So then it came to us and the REVEAL trial. And again, that finished in 2017 and was announced at the European Society of Cardiology that year with publications in the New England Journal. You can imagine after this slightly checkered history, at the point at which we came to lock the database and break the code, we were slightly worried, and we did really feel like the last man standing in a group of drugs that hadn't done fantastically well. The trial, 30,000 patients, all aged over 50, all of them with vascular disease at baseline. They were all on a decent dose of a statin, and then they were randomised to anacetrapib or placebo. We followed them for at least 4 years and made sure we had enough events to have a statistically reliable answer. The primary outcome being a composite of coronary death, myocardial infarction, and coronary revascularisation. And the results of REVEAL were very interesting. You can see the rate of primary outcomes in the placebo group rising, as you would expect over time. And in those allocated anacetrapib, they remained rather similar for the first couple of years, but then we started to see that divergence. And overall, a 9% reduction, proportional reduction, in major coronary events. It's worth noting that first 2-year bit, because it's not really any great surprise that there's no difference early on. We know that atherosclerosis takes years to develop, and so we're kidding ourselves if we think we can reverse it overnight. And on top of that, previous trials of statins have shown us very clearly that there is a lag effect. Statins typically take about 6 months to a year before you start to see any of the benefits. So it wasn't really a surprise to us that there was that delay. So overall in REVEAL, a significant 9% proportional reduction in major coronary events. It appeared to be very well tolerated. There were remarkably few side effects, although the drug does seem to hang around in your fat tissue, in your adipose tissue. We didn't see any hazard in terms of excesses of mortality, cancer, or any other adverse events. And we're still following up those patients, at least for another month. We've been following them for an extra 2 years after the end of the study to make sure that there are no delayed effects of that drug. Before I move on, I just wondered if you might afford me a little bit of artistic license to superimpose the Accelerate results onto those of REVEAL. I've adjusted it to the same time scale, but the event rate is different because their primary outcome was a different event. They had a lot more items in it. So I think it's not unreasonable to do that. And I think it demonstrates a really important point. In fact, it's remarkable that it fits so well. But the point is, if you don't design your trial appropriately, you might miss the right answer. You have to be patient. You have to give things time to work. It's important to be patient, and it's important to get the right answer, because otherwise you might throw away a drug that could have been incredibly valuable for patients. Evacetrapib from this other trial could actually have had a really good place clinically. But unfortunately, that's not to be the case, because it wasn't tested properly. So finally, let's come to Orion 4 and the current project. Orion 4 again is in the cholesterol arena, looking at a slightly different target, PCSK9, pro-protein convertase subtlysin kexin type 9. I hardly ever say that because you wouldn't, would you? PCSK9, which is a circulating protein produced in the liver, and it's very directly involved in LDL metabolism. So higher levels of PCSK9 give you a higher level of LDL cholesterol, which you think is a bad thing. Lower levels of PCSK9 give you a lower level of LDL cholesterol, so we think that's a good thing. And indeed, there are already agents out there that are available that target PCSK9. They're monoclonal antibodies that neutralise it in the circulation. So evolocumab and alirocumab are available for clinical use. They were both studied in very large trials, really very large in terms of the number of countries that were involved, 50 countries in each case, 1,200, 1,300 sites, absolutely mammoth efforts, these studies, to try to answer the questions about these two agents. And again, they only followed up patients for just a couple of years, which does seem quite limited, although there's no doubt that they saw a very clear result during those couple of years. The one thing that slightly bugs me about those trials is the cost of them. Each of those trials cost more than $1 billion US, which is not really sustainable. If a company has to spend that much money on one drug that might not end up being successful, then they're going to have to ditch a lot of other stuff by the wayside. They're not able to follow all of their possible targets through. And so what could be good drugs aren't making their way to us as clinicians. And that's frankly wrong, and it's not necessary for trials to cost that much. We managed to do it historically on much smaller budgets. So for Orion 4, that was one of the challenges, was to really change the mould. In Orion 4, we're looking at a drug called inclisiran, which also lowers this PCSK9 thing, but it does it in a slightly different way. So if you go back to your school biology, you'll remember that DNA is transcribed into RNA, and that then produces the messages which translate into proteins. And the way this drug works is it interferes with that RNA step, so the protein just simply isn't produced at source. And as a result, it has a really impressive duration of action. You only need to give it about once every 6 months by subcutaneous injection. So that's really promising, because I don't know about you, but I think most people, if they had the option of taking a tablet every day or an injection once every 6 months, maybe even once a year, I think you probably know what you'd choose. So we're studying inclisiran in Orion 4, aiming to look at the effects of it on major cardiovascular events. We're going to randomise 15,000 people aged over 55, all of them with vascular disease at baseline, and we're going to follow them for at least 5 years, making sure we get a really clear and reliable answer. As opposed to those other studies that had 50 countries, we're just going to do it in 2, the UK and the US. We're going to have just about 150 sites or so, not 1,500. And the hope is that we'll have 12,000 patients in the UK, 3,000 in the US. So a really very UK-centric trial. Very important, actually, in terms of demonstrating the UK as a really excellent place to do clinical trials. So 2 countries, 150 study sites, 15,000 participants. And we think that brings with it a huge amount of efficiency. And with that actually comes better quality data. But beyond that, this trial is even more than that. It's a new way of collaborating with academia. We're sort of going hand in hand with the medicines company who produced the drug in a co-sponsorship arrangement because they equally think that the model for trials has to be changed. We can't spend $1 billion on a trial. It's just not sustainable. So they're working very hard with us to improve matters and to really keep things simple so that we get a reliable answer to our important question, but don't spend money unnecessarily. We've only just started recruitment for the trial. The first 2 patients were randomised just last week. But I think it's got an awful lot of potential. It's a really exciting new-looking drug. It's this very exciting mode of delivery, this sort of vaccination, if you like, 6-monthly or maybe even annual injections, which I think could have potentially huge potential health impact. It's this very exciting academia and industry collaboration, and as such, it's actually already been cited in the UK government's Life Sciences Industrial Strategy, which is slightly scary. It feels like quite a lot of pressure, but there we go. And I think it's a really exciting opportunity for us all together to transform clinical trials. So, having brought us up to the present day, I think it's time for me to say a huge thank you, in particular to all of the trial administrative staff, programmers, trial managers, nurses, monitors, clinicians, who actually make all of this stuff happen. I can't really take the credit at all, and it's an absolute delight to work with such a remarkable team of colleagues across the board. Slightly hypocritically for a diabetologist, I know. I have a bit of a habit of saying thank you with cakes, which is another practical hobby of mine. So if you've had a slice of any of these, you know who you are. I'm not going to risk listing any names because I know I will forget somebody. I'm working on some cake ideas for Orion 4, but we've got another 14,998 patients to find first, so I've got a bit of time yet. But I do want to single out just a handful of senior colleagues, without whose support and mentorship for the last 18 years, which is quite frightening that it's 18, I wouldn't have known how to make the most of the opportunities that I've been fortunate enough to have received. And of course, I wouldn't have got Martin's job. And particular thanks to my family for putting up with the other side of that supposedly calm exterior that you all seem to comment on here at CTSU. My husband Neil, my daughters Zoe and Ruby, my brother Matthew, my mum Susan, they can all certainly tell you plenty of stories that I think would counter that suggestion that I'm always calm and don't get angry. So it was all a bit of a meander, but I hope I might have shown you a little bit about why I love my job so much and why maths was a good starting point, even if it's not where I ended up. There's one final word that I'd just like to add into this list, and that's one that I'm shamelessly plagiarising from my dad in true academic style, and that's pride, but in the purely positive sense of the word. My dad unfortunately died with metastatic pancreatic cancer 2.5 years ago. It's a great shame he couldn't be here for this. It was absolutely his kind of thing, and he'd have openly been the proudest man in the room. This photo was taken at the Royal College of Surgeons in 2011, when he was awarded the Sir Frank Collier Gold Medal by the Faculty of Dental Surgery. I think it's quite prestigious. I was able to attend that ceremony with Mum, and as part of the award, he gave an address to the newly graduating fellows of the Faculty of Dental Surgery. His chosen topic was pride, noting that that's not always a good thing, but on this occasion it was entirely appropriate for the audience of graduates and their parents to be really proud of the achievements that were being celebrated. But actually what he really wanted to stress to this future generation of dental surgeons was for them to take great pride in the quality of their work and to make sensible decisions about their practice to ensure a lifetime of excellent results. I think Dad's lecture really struck a chord with me with respect to my own work colleagues, and I think it's fair to say that it's the remarkable, absolutely universal dedication to producing high quality results and getting the right answers to important medical questions that unites us all. Thank you very much.